The following video will describe tips to identify secondary rhegmatogenous retinal detachment and its subsequent surgical management. Clues to identify secondary rhegmatogenous retinal detachment are sclerosed vessels, break under the fibrovascular membrane, presence of a posterior break, associated vitreous hemorrhage, and finally presence of a subretinal bleed. Surgical management of secondary rhegmatogenous retinal detachment involves core vitrectomy followed by attempts to induce a PVD. In patients with tightly adherent fibrovascular membranes at disc, a plane is created nasally, followed by extension circumferentially all vitreous connections to the disc are separated in this step. Pre-operative intravitreal anti-VEGF may be used in patients 3 to 5 days prior to surgery depending on the vascularity of the fibrovascular membranes. Debulking of peripheral vitreous is done, followed by dissection of fibrovascular membrane. Vitrectomy settings used are low vacuum with a moderate cut rate. Meticulous dissection of fibrovascular membrane can be done with a 25 gauge vitrectomy cutter once the appropriate plane is determined, followed by diathermy of any bleeders. Attempts are made to relieve all traction on the retina by careful dissection of membranes. Careful use of other instruments such as the ILM peeling forceps may be done to remove residual islands of membrane, followed by diathermy of bleeders. Adequacy of diathermy is assessed by lowering the intraocular pressure. Similar principles are followed for dissection of other fibrovascular membranes present. Peripheral shave vitrectomy is completed. Nasal retinotomy is created using diathermy followed by air fluid exchange. Endolaser is done. Extent of endolaser depends on the underlying pathology. The choice of vitreous tamponade is as per surgeon's discretion.